Okay, we're coming up on the hour with lots to cover. So I think I'll get things started and people can join as they arrive. So hello, everyone. Lovely to see you here today. I'm really pleased to welcome you to our final Keeping Up with Knowledge translation session of the year. Hard to believe the year is almost over. My name is Rachel Jackmantonio, and I'm the Knowledge Translation Coordinator with the MSSU, and I'll be your host this afternoon. If you're not familiar with the MSSU, we're one of 11 SPORE support units across Canada that support and conduct patient-oriented research, and we work in all 3 maritime provinces. Before going any further, I want to offer a land acknowledgement that reflects my location here in Shubucktuk or Halifax, and I want to acknowledge that I'm in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725. The treaties did not deal with the surrender of lands and resources, but in fact recognized Mi'kmaq and Wolastoqiyik title and established the rules for what was to be an ongoing relationship between nations. We are all treaty people. At the MSSU, we're committed to developing authentic and meaningful relationships with Indigenous communities and supporting the inclusion of diverse perspectives in healthcare research across the Maritimes. And as a part of that commitment, we also recognize the histories, contributions, and legacies of African Nova Scotian people who have been here for the last 400 years. And I recognize that some of you will be joining us from other locations across the country, and so I invite you to add a land acknowledgement to the chat that recognize the lands where you live, work, and learn. And speaking of learning, we'll be talking today about learning health systems and how to bring that concept to life. And so before I dive in, just a couple of sort of semi-obligatory housekeeping notes. I feel like we've all heard these so many times by now, but please mute your microphone if it's not already. We are recording the session, so the video will be available on the MSSU YouTube channel afterwards. Closed captioning is enabled, so anyone who would like to have the auto-generated caption showing can fix that in their settings. And if you have questions throughout the presentation, feel free to type them into the chat. And if you'd like to kind of join the discussion and sort of unmute yourself and ask them, just include your name alongside the question. So without further ado, I will stop sharing my screen and introduce our speakers. So first, we'll be hearing from Dr. Christine Cassidy, a registered nurse whose program of research at Dalhousie and IWK Health uses an integrated knowledge translation approach to design, implement, and evaluate evidence-based practices in pediatric care and to advance the science of learning health systems. So Christine's going to give you a whistle-stop tour of learning health systems and sort of the concept behind them. And then Dr. Amy Grant, the MSSU Director of Research, will walk you through a new graphic that we've created to kind of illustrate the components of an LHS and talk to you about some supports that are available through the MSSU for people taking an LHS approach. And last but certainly not least, Jennifer Taylor, an MSSU patient public partner who serves on the MSSU LHS advisor group that developed that graphic, will share some reflections on the role of patients and communities within LHS. So we're aiming to do all of that in about 30 minutes. And then we have a quick poll that will run with all of you at the end of those remarks to kind of kick off a discussion. Hopefully we'll have some time left for that. So I will hand things over to Christine to get started.
Great, thanks, Rachel. I'm just going to share some slides. And can you let me know if you see presenter view or regular view? Oh, Rachel,
I'm seeing presenter view.
Okay, we'll switch. How's that?
Better.
Okay, awesome.
Okay.
Welcome everyone and good afternoon. Thanks to the MSSU for the opportunity to share some of our own work on learning health systems, as well as some work that the Learning Health System Advisory Group has been conducting over the past little bit. So I've been tasked, as Rachel said, to bring you quickly and briefly through the concept of learning health systems. What are learning health systems? What do they include? What does this look like? And so learning health systems is a term that's been floating around for several years now. And personally, I find it hard to be able to wrap my head around it. There's been some really important foundational work on learning health system, the concept of it. What is it? What does it mean? What does it include? This definition here is one of the earlier definitions from the Institute of Medicine. An environment, a learning health system is an environment where science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process, new knowledge captured as an integral byproduct of the delivery experience. I'll be honest, I find that is a lot of buzzwords. I'm not even really sure what I've just read, and I've read this definition a lot. So personally, I find this definition a little bit easier to wrap my head around. So this is from the Agency of Healthcare Research and Quality, and it really focuses on internal data and pairing that with patient experience data, seamlessly and systematically integrating that with external research evidence. And collectively, that is put into practice. And what I especially like about this definition is the focus on outcomes. So it's really starting to lend itself towards the impacts of the quintuple aim, where patients are getting higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. When you start to dive into these definitions, it's helpful to understand, okay, what is actually included in this overarching concept of learning health systems. So Labus and colleagues describe learning health systems as having 4 core components and 7 key characteristics that are listed on this slide here. So to start, learning health systems are data and evidence-driven. They bring in the health system, patient experience data, along with research evidence. Learning health systems are patient-centered at the core. So communities and patients in an ideal learning health system are engaged throughout the process and in decision-making. Learning health systems are supported by the appropriate decision support systems, aligned with governance and financial arrangements collectively to support the learning health system. And the last piece is that learning health systems have a culture and competencies to support that rapid cycle that we mentioned in the definitions of learning and improvement. Some of this foundational work on learning health systems has led to the development of different learning health system models. And these encompass the different components of a learning health system. At the crux of most of these models is really that continuous cycle of practice, producing data, which then leads to evidence, is integrated with external research evidence, and then that is put back into practice, and the cycle continues over and over. Conceptually, I think this makes sense. I think these models are quite pretty. But our team at the IWK, we were looking at these models a few years ago. We thought, okay, and we were looking into the literature, lots of description about what a learning health system is. But we were really stuck with this question of how do we implement a learning health system? What does this look like on the ground in practice? So as researchers, we went to the literature, and Mari Somerville, who is a CIHR Health System Impact Fellow with us at the IWK, led this extremely comprehensive mixed method systematic review that was just published a couple weeks ago in Health Research Policy and Systems. I encourage you to take a look at this paper. There's lots of golden nuggets that you might find interesting. But one thing that we looked at in this review was how learning health systems were described in the literature and what components were they focused on based on those 4 components that I mentioned earlier. So the majority of papers that were included in our review did a really good job of focusing on digital data capture. So they were capturing patient health information, administrative information, and all of that data was captured digitally. The components of a learning health system that were missing more often were things like patient engagement. So patients weren't engaged in the learning health system decision-making process. And although they were collecting data, they didn't have this culture of using that data for rapid learning and improvement. So our next question was, okay, we know what this looks like in the literature. What does this look like on the ground in our local context at the IWK? And for those of you that are joining perhaps outside of the Maritimes, the IWK Health is our Women and Children's Tertiary Care Center here in Nova Scotia. And so one brief example of how we examined learning health systems in our local context was with COVID. So I'm sure it's not too hard for all of us to put ourselves back in March 2020, when the coronavirus we were hearing about became a global pandemic. And during that time, we were seeing a range of health system interventions that were quickly designed and implemented. Significant restrictions were being placed on our social and healthcare systems. And this was a rapid change to health systems that really, have been traditionally known as slow to transform. So again, as researchers, we saw this as an opportunity to explore how health systems were adapting under rapid and constant change. So we wanted to know, how was the IWK working or not working as a learning health system? And so we conducted a study where we mapped the assets and gaps of the IWK's earlier pandemic planning and response using a learning health system framework. So this was published in PLOS One, and some highlights from this work and some key takeaways from this study was that the importance of engaging patients from the get-go. So many of our usual ways of working in the health center based upon those principles of patient and family-centered care, those were limited during the early phase of pandemic planning and response. Restrictions on family presence, does not need to replace the principles of family-centered care. So moving forward as a learning health system, is transforming as a learning health system, patients really need to be engaged in the decision-making and get creative about how to engage them, not just in research studies. The second piece was improved data capture. So the organization really did the best that they could under very strict timelines, but a true learning health system will not be realized without adequate digital data capture of the care experience. That's the critical piece here. So we need to be building digital infrastructure in health system organizations that include care experience data, process outcome indicators, together to inform those rapid cycles of learning and improvement. This study also highlighted that health system research structures and partnerships that support that timely inclusion of evidence weren't necessarily used in the early stages of the pandemic. And so it highlights, as a learning health system and transforming into a learning health system, the need to enhance the role of embedded researchers. And lastly, a key finding and key takeaway from this work is that the organization was really operating in many ways as a learning health system, even pre-pandemic. And so building on and leveraging those assets they have as a learning health system to fill in the gaps and moving forward for other rapid responses, perhaps not necessarily for a pandemic, any type of health system priority that comes along. And so, like I said, that was a quick overview of learning health systems, the concept, some of the work that we've been doing to try to advance the concept of learning health systems and the science of learning health systems here in the Maritimes. But I'll be handing it over to Amy to see how we're building on this work to support learning health system transformation in the Maritimes.
So I'm going to now share my screen. Just a second here. Screen 2. There we go. And I'm on the right thing. Awesome.
Yeah, you're good.
I just can't see my, there we go. Okay, so that was succinct, and hopefully I can do my job succinctly as well. But you had the hard job, and I have the easy part of just describing the recent work that we've done at the MSSU around learning health systems. So I guess the first question you might be thinking about is, why are we talking about learning health systems at the MSSU in the first place if you're not already involved in some of the work? So just to, I guess, describe this, is in phase 1 of kind of our funding, which ended in 2022, we had a focus on what we call core components. So data platforms and services, methods, support and development, capacity development, patient-oriented research, amongst these kind of other areas as well. And then with the phase 2 of funding, which started in 2022, things were kind of consolidated into a smaller model, kind of encapsulating some of the parts in phase one, some having kind of their own distinct focus. And one of the new parts is learning health systems. So new in some ways, I guess, is the message, but also the same in many other ways. So as Christine mentioned, we've all been working around what actually is the learning health system. We can read a definition and understand all the words, but like really understanding what it is has been something that we've spent a lot of time doing in the first part of our work around how does the MSSU fit into this definition and what is our role in that. So that's kind of what I'm going to talk about in this presentation. So to give you a sense of what our plan is we have a Learning Health System Advisory Group that advises on the direction of how we support learning health systems within the MSSU. And so we've kind of outlined different phases of how we'll support learning health systems. So this is kind of our current work, and then this will transition into some new work in 2024. But one of the first things that we identified in figuring out kind of what our place was in all of this is we thought we could develop a toolkit that would help with implementation of learning health systems. So that's kind of our starting point, and that's kind of what this presentation focuses on, but also it allows us to move into the next phase, which is highlighting LHS success stories. So this presentation is one of a series planned to talk about learning health systems. So this sets kind of the background for how we're moving forward, and then we're moving into that next piece about sharing those stories. So when we started off looking at a toolkit, what we, of course, the best place to start and where we're always grounded is what already exists. Can we do this without making more work for ourselves unnecessarily? So surely someone has a toolkit we can use that we could adopt and then implement here locally. So what we did is our evidence synthesis librarian, Christy Hancock, did an environmental scan of learning health system toolkits. And there were no limitations on where these could be from. And what we identified in the end, this consolidated version, is 7 kind of strong examples that we thought encapsulated some of the components that we wanted to really talk about and that would be helpful for us moving forward in figuring out how to implement or support learning health systems. So we brought these back to our advisory group for feedback. We talked about the things people liked and didn't like, but in the end, what we saw really was that no toolkit was perfect for kind of fit for purpose. They all had different helpful pieces, but no single toolkit was kind of ready to move forward with and implement. And we didn't think that any of them would really help us in our quest to figure out what our role is in supporting a learning health system. But what we did see was that there were many graphics. Again, Christine showed, I think one of these is one of the ones that Christine showed as well. There's many graphics kind of showing learning health systems, how they work in different ways, and they were all kind of tailored to a group's individual context. So, and you'll see the Quebec Learning Health System Support Unit here. So these were all kind of exemplars for us in figuring out, well, maybe our next step is to really situate ourselves within this learning health system model and figure out how the MSSU can fit into this and support learning health systems. And so we decided to jump on the bandwagon of making our own graphic, which we thought was unique at the time. But in the last year, I think many other groups have also done similar things, which is great because the goal is really to make it context specific and fit for purpose. So specific to our organization and how we fit into this. So rather than kind of create a new toolkit, we decided to map how MSSU already supports learning health systems. So our modified goal was to do this instead of the toolkit. And we used a prominent learning health system graphic as kind of inspiration, so to speak. But you could probably look at any of the graphics out there and see their relatedness between them. But I think many of them are also based on this Minier paper that's referenced here as their starting point for creating their own graphic. And so just so you can see what this looks like in relation to ours, and go to the paper if you're interested. Again, this was described by Christine, is that we have this cycle of learning from practice. Practice generates data. That data can be transformed into knowledge, and that knowledge can then be transformed into practice. So we have this continuous cycle of using data and moving that into practice is the idea of a learning health system. But also a learning health system can be at a health organization. It can be at an individual group. It could be, you know, in a clinical unit. It doesn't have to be one thing. It doesn't have to be just the healthcare system. So I think that part for me has been hard to kind of conceptualize, because I think when we initially think of learning health systems, we think of our health authorities, our hospitals, but it is more than that. It's this, I guess if you want to use the words on the slide, this ecosystem of change, right? So using data in this kind of continual cycle to inform what we're doing and learning from that. So I did a Google search just in preparing for this to see, like, you know, I know there are many models out there, but wow, there are a lot of versions of this learning health system model out there circulating. So it definitely, I think, is becoming a bit of a buzzword, and this creating graphics to describe how your organization is supporting this is also a bit of a thing that's happening, which is important in figuring out how we do move forward, and also in identifying, I think, gaps in parts of that model within a group, health system, organization around what you really need to make this work. And again, those examples that Christine showed, I think, also highlight what are some of the gaps in that specific health system. And I think those are probably pretty common gaps that you would see. So this is a pretty simple piece to describe, but just so we can kind of recognize the contribution of different individuals to creating this graphic. So we use a combination of educational resources and links to services. We also wanted to make the graphic interactive. So with the help of our advisory group and insights kind of around accessibility from our patient public partners, we decided to use pop-ups so we could keep it pretty simple, but then also link out to more information and more resources. So you can see some of those other models, they're great, but some of them are very descriptive. So you kind of get tied up in the details. And so the aim of ours was to really make it relatable so that anyone could kind of open it up and get a sense of what was happening. And then, you know, depending on your interest and your background, you could dig into more resources that you wanted to learn more about. So we created this with a graphic designer because it looks like it is easy once you look at these graphics in the end, but we spent a lot of time debating about words and the placement of arrows and all those little details that you do kind of consider when you're coming up with an infographic. And it's gone through several rounds of feedback with our advisory group, our science teams, our EDI team, our sex and gender team. So there's been a lot of kind of hands and eyes on this, but also in the spirit of continuous improvement, we're also happy to receive feedback on any aspects of this that you think could use some help. So it's not necessarily a big drum roll like when we first presented this, but to some of you it might be if you have not seen this before. So this is our Maritime Learning Health System graphic. It is up on our website, so it's accessible to everyone there. And you can, and I'll show you the interactive version of this as well. So it also links to a PDF if that's something that's easier for you to look at. We can also email that out to anyone who might be interested in receiving it that way. So you can see again, this describes the cycle data, knowledge to practice and policy. So our goals with this were to make the language a bit more accessible, a bit more relatable, I guess, so to speak, and to keep it pretty simple. So the idea is that we use the data and knowledge while also engaging with community. So we put community at the center of this, which again is in the spirit of learning health systems in general, but really as a focus in that it's everyone is the community. And this is again something we debate about quite a bit, is who is community, and it is everyone. So even if you're a clinician, you're also a member of the public, right? So we need to learn from community as partners in this work, in research, in quality improvement, in all aspects of work that would inform this learning health system approach to inform policy, practice, and outcomes. And again, the cycle is continuous, and our idea here around equity is that it's part of all of this. So it's part of each piece of this puzzle and should be considered in all kind of aspects of this, as well as research and evaluation. So research doesn't have to be a part of every kind of thing that happens within the learning health system approach, but really there needs to be some type of evaluation, measurement of what's happening in order to improve and learn from that knowledge. Just going to make sure I hit all my main points. So I've heard some people ask questions lately about, identifying key parts of learning health systems that are in need of support. So I heard a question recently around, can you give examples of like who to contact in an organization if you wanted access to timely data? And I think no one in the seminar or the meeting had an answer, and again, in a national audience, because it is hard to find access to timely data about the things that you need. And again, that was highlighted in a real world study here in Nova Scotia. And so there's lots of gaps in this model in how we can actually enact a learning health system in different organizations because of the difficulty in accessing data, the difficulty in making patient voice part of the process if those processes aren't already embedded into the organization. So there's definitely work to do at all of these levels in order to support a learning health system. So I'm going to now put up here we go. Our interactive graphics. You can get a sense of what this looks like in more detail. So this is the full model with definitions alongside each component. And then also, if you click on this, you can have access to our resources. So in terms of how MSSU fits into a learning health system, we saw that a lot of the things we already do support different components of a learning health system. So that's kind of where we're placing our role in all of this and supporting implementation of learning health systems in the Maritimes. So you can click on each of these links to take you to different resources on our website, such as evidence synthesis, trainee funding, request a research consultation. And so each arrow links out to those different pieces: knowledge translation, implementation science, data platforms, apply for data access. So those are the ways that we support these components. But again, they will look different in every organization or system that you're looking at. And sorry, the problem with two windows when you're presenting is that you get lost in them. So I think I just have one more slide here. So I wanted to kind of just bring you back and kind of show you our core components and then the graphic, because I think again, how does MSSU fit into all of this? So really, a learning health system is anchored on patients. And of course, as a patient-oriented research support unit, we are also anchored on patients, or aim to be as much as possible, and are always kind of improving those processes as we go. And we're focused on, timely data and evidence. And we have at MSSU a focus on data platforms and services. And we're bolstered by governance that's aligned with learning health system goals. So really, it builds on this culture of moving evidence into practice and doing that more quickly. And so that's definitely a focus that we have, and it's a core kind of focus of learning health systems. So I think those are the main pieces that I wanted to share about the work that we've done so far, with lots more planned moving forward, and looking forward to hearing everyone's thoughts and questions as we move on. So Jennifer, I'm going to hand it over to you, and you can just let me know when you want me to advance the slides for you.
Okay, thanks, Amy. Christine and Amy have talked about the model and the infographic we've created. I'm here to talk about some of the people who are at the heart of the community depicted in this model. Obviously, the academic researchers are quite important, but I'm more familiar with the people on the health system side of this model. And it might help to put what I say in context if I tell you a little of my own story first. I'm a patient in the healthcare system. I use more resources than many people my age because I have multiple chronic conditions associated with an underlying genetic condition. The chance of passing it on to your children is pretty high, so other members of my family are affected as well. I try to help them with system navigation, which, as you know, is often not very easy. They count on me to help with that because I'm a retired nurse who worked for decades in the healthcare system. I've worked in a hospital, in private industry, and in a community health clinic. I've been a bedside nurse, a clinic nurse, a disability case manager, a staff educator, and a nurse manager. I've probably worked with every type of health professional and support person at one time or another. Along with the patients and academic researchers, all these people are a very important part of a learning health system community. I'll be sharing some of my thoughts with you today based on my own experiences about challenges and facilitators some of the people using and delivering healthcare may experience with contributing to a learning health system. So how do you build your LHS community? The challenges to participation that I came up with, though, when I realized that, were basically the same for everyone. It got even more interesting, though, when I realized that the challenges these people are facing can also be facilitators, which could support us in becoming a learning health system. Next slide, Amy, please. When a patient is experiencing a health crisis or change in health status, they just want to get it looked after. They probably aren't ready to talk about studies or systems. Health professionals and the people who work in support roles are focused on trying to address those immediate patient needs too. A recent article in Canadian Nurse was titled, "The Soul-Crushing Reality of What Happens When Patients Are Forced into Crowded Emergency Departments." This is our reality right now. And people working in that reality are just trying to get through their soul-crushing shifts and trying to make sure that no one dies on their watch. The flip side of that challenge is that people using and working in the healthcare system see clearly that approaches we've been using are not creating changes that are needed to keep our system running well right now. There's no doubt there's an urgent need for change in our system, and this urgency can actually be a strong facilitator for people to change the way that they do things. Although there's been work going on for a number of years on LHS, I don't think there's a lot of awareness about it yet on the front lines of our system or in the general population. Patients haven't really heard much about research or practice models in the past, so they probably won't be looking for one. A lot of people working with patients don't pay a lot of attention to models either. They've seen them come and go and only heard about the models briefly when changes were introduced. They often had little to no input on those changes. If you ask people working in healthcare what they think about change, a lot will probably tell you to just stop. They're tired of the constant change that's confronted them throughout their careers. It's hard to convince people that yet another model for change is going to be helpful when we're in such a mess now, even after using models that were supposed to help improve things before. On the flip side, though, there's been some good experiences that came out of some of those models. When I was an educator, I provided team building workshops to departments that requested them as part of the change management approach. I designed the workshop so that people worked together on SMART goals for change in their department. There were a lot of great ideas and many that cost little or no money to implement. One group wrote a SMART goal for exactly how they would welcome float nurses who came to help out on their unit. Eventually, I started to hear that float nurses knew which units had done team building sessions without ever being told. When there have been some successes tied to the models we've experienced, it's a little easier to sell another model. Nobody wants to make time for things that are too complicated if they can avoid it. It takes time to understand what the LHS model is all about and how it differs from other approaches we've used in healthcare. And as we know, time is a very precious resource. For some, we can start by building on what they know about other models. Others will need to start by learning how a model can be used and then learn the additional details. We're used to the top-down approach where decision makers told us what to do and how to do it. Health regions are pretty big now, so regional approaches haven't always worked well at the local level. The biggest difference is that people working in patient care and patients themselves can play a much bigger role in needed changes in this model. Rather than saying, here's the study or the intervention we've developed, and now we need your help, individuals from the whole LHS community can have a pivotal role in determining what needs to be studied, how it will be done, and how the outcomes can be used to help them. They have an opportunity to gain understanding before changes are introduced. If they know about past successes in research that have touched them personally, they're more engaged in learning what they need to know. I've had some of those experiences, and that does keep me engaged. I think one of the biggest challenges in getting patient partners is getting them to believe that their input would actually be valued as much as the healthcare professionals and the academic researchers. Some people have never interacted with academic researchers, but I think we've all interacted with people in the healthcare system at one time or another. Unfortunately, some patients have had some really negative interactions in healthcare settings, especially those with complex care needs. It's tough to get people on board when they haven't felt respected or valued by the people in the professions they're being invited to work with. People working in healthcare have also had some negative experiences. A question has come up at times when changes are being introduced. When we tell them there's a better way to do something, people ask, "Don't you think we're doing a good job now?" And people can get a little offended by the phrase, "work smarter, not harder," like they weren't smart enough to begin with. Good relationships make conversations easier, though, and people are less likely to question whether or not they are respected. Time spent building those relationships hasn't always been valued, but it's really necessary if you want to get things accomplished. Respect for people's time is important. People working in healthcare are repeatedly asked to take on just one more task, like research, without being given any extra time. In many cases, they're already struggling to provide adequate patient care. So if the LHS work is important, it's important to make sure people have time to do it. I went to a presentation recently about a study that was being done and was impressed that research assistants were embedded on the nursing unit to collect data. I was even more impressed, though, that one of the things they addressed at the very beginning was to get input from the nurses on how they could collect their data and stay out of the nurses' way so they didn't affect their patient care duties. They showed respect for the nurses' time, for their responsibilities, and for their opinions. These types of positive experiences facilitate those ongoing relationships and contribute to learning health systems. In the chronic illness community, I've run across a lot of people who want to contribute to the healthcare system. They've gone through some really difficult experiences and learned some valuable lessons. They want others to benefit from what they've learned, and they want people working in healthcare to acknowledge that lived experience. That doesn't always happen, though. Sometimes people in the healthcare system are condescending about what patients say or try to share. Many people with chronic conditions that are not well understood may actually know more about their condition than the people they need to depend on for their care. You get to learn who you can discuss information with and who you just have to put up with. A GP I used to have told me she had never been able to find any information as good as what I had shared with her about my condition, and that she was using it to help other people. Another time, an ER physician asked me to share with him what it was like to live with my condition. But then there are days when some physicians are very condescending. I don't even try with those people, and if I have a choice, I don't ever go back to see them again. People working in healthcare also want to contribute. If you ask people why they became a doctor or a nurse or another type of health professional or support person, they often say they want to help people. That seems to be true for the vast majority of people I've worked with. Some of them have made some really big contributions that are given special recognition, and some contribute every day in a more quiet manner by making sure their patients and sometimes their coworkers are well cared for. If they can see real benefits for their patients and themselves, they're a lot more likely to be engaged and want to contribute. This is especially true if what they're learning is put into practice while the learning is still fresh, and they can easily see that their contributions are making a difference. The Learning Health System model opens the door for every person involved to contribute in a meaningful way. I hope my experience has helped a little as we all try to better understand this model. Now I'm going to hand you back to Rachel.
Thanks, Jennifer. And thanks to all of our speakers. It was not a small task to kind of introduce us to learning health systems, talk about available supports, and also, Jennifer, thank you for kind of enriching our understanding of the role of community by so well illustrating how bringing those different perspectives help to understand how these systems can work or not work, those barriers and facilitators to their implementation. So at this point, we wanted to use the remainder of the time to kind of open up the discussion with the group. And we had a few questions of our own just to kick things off. So I am going to share my screen now, and I will drop the link to the poll once I get that started into the chat. And then if people want to follow along and answer the questions, they can. So hang on one second here. I'm going to open the chat up again. There we go. So there's a link now in the chat to this poll, and I'll put the information on the screen too. You can go to menti.com and put in this number, or if you just click the link in the chat, it should take you directly to it. I'll leave this up for a second. And then Christine, if you want to come on, you can walk us through.
Sure. Thanks, Rachel. And thank you for putting together some questions to get the conversation started. So for those of you that have joined us, please feel free to answer via this Menti poll. Also, this is very much an open Q&A period, so feel free to ask questions or provide comments in the chat. You can unmute your microphone and jump in. We'd like to take the last little bit of time to understand this concept from your perspectives as well. So it sounds like a bit of a mix around learning health system approaches, but not calling it that. And I think that's definitely what we have found in our work and with the Learning Health System Advisory Group at the MSSU around, is this just the same thing, but packaged in a different way? Or what are the components that are a little bit different that we need to be focusing in more? And so it's interesting to hear from the group that that's consistent across the board.
Absolutely. And then I guess with this next question, there were some people who said that they weren't taking an LHS approach. And even of those that are taking an LHS approach, do you feel like your institution is as well? So kind of we talked about how it can exist at different levels with a project, an institution.
Or even a team or a community. So it's taking this model of seeing how to use different types of data and evidence, patient engagement, along with that rapid cycle of improvement. So it's good to see that even if it's not being called this type of approach is starting to be used a bit more in different institutions, organizations, and teams.
Yeah, sure. Oh, this one seems to be having trouble loading. We're going to ask about barriers. Jennifer had identified some barriers and facilitators, but all we seem to have is the bollard, as the British would say. I'm not sure why that's not working. Let me see if I can figure it out in the background here. Oh, is it going to work? Something has happened.
If not, feel free again to add them in the chat, or if you want to share with us. We just are curious around building on what Jennifer was saying about the barriers to transforming, advancing this idea of learning health systems. We'd love to hear from the group, whether it's a comment or a question.
Yeah, so if you're thinking of any barriers or facilitators, maybe put them into the chat. It doesn't seem to be liking this slide. We'll try the next one.
Perfect. What supports do you need? So thinking about especially those of you that answered no to some of the previous ones, now that you might have a better idea about learning health systems from this presentation and from the MSSU's graphic, curious what types of supports you would need. And please know that we're taking this information to help inform our work as part of the Learning Health System Advisory Group at the MSSU. So would really appreciate any thoughts on where we should be going with our next couple of years and the work plan that we'll be developing. So some resources, training.
I'll flip ahead. I see there's an other, so feel free to drop your thoughts on the other into the chat. We did have the next slide was supposed to allow you to put open-ended recommendations in, but doesn't seem to like the open-ended questions when I'm sharing my screen. So drop your other thoughts into the chat.
Yes,
it's
please.
Really helpful. And as Christine said, there is a bit of work planning happening around these areas. So it's a great time to bring any ideas forward. Okay, so I think our last one was just around, we mentioned that there were supports in those different parts of the LHS cycle, and just whether or not there was a lot of interest in accessing those, gauging the interest out there. Okay. And I think this was our last question in the poll, so we'll just open it up to the floor. Does anyone have any questions for our speakers about any aspects of what we've been discussing today? LHS more generally, the model or available supports here in the Maritimes, sort of the role of community within LHS. Feel free to drop them in the chat or raise a hand. Give you a second to do that. Okay. I'm going to stop sharing the poll now since we've gotten to the end. Okay, so not seeing any showing up yet. Please feel free to keep thinking of them. I had a few prepared for you. So I feel like this is a really common one that I've seen in a lot of places. But what do you think are the sort of biggest differences between the learning health system approach and kind of other ways of learning, particularly around quality improvement or maybe research? How do we kind of distinguish this from those other activities? And I guess I'll throw it to you, Christine, first, since it's a big general LHS question.
Sure. Excuse me. And I'll give, I feel like a lot in my presentation too, I provided my perspective of my own journey of trying to figure out what learning health systems are. So keeping that in mind, the way that through my own reading and conversations and trying to learn more about learning health systems, I view it really as a culmination of many of those different components. So we have lots of methods in knowledge translation and implementation science that are so valuable to bridging that evidence to practice gap. And I see that as kind of being a component to a learning health system, along with patient engagement, along with using data, along with this culture change within organizations or teams or communities. So I see it as I think on the one hand, a way to bring it all together. And then on the other hand, I'm starting to see it a bit more as almost health system language. So it's really focused on value-based health systems that I think health system administrators, health system leaders, CEOs, VPs can get behind a little bit more than more traditional research language. So that's kind of the two ways that I'm seeing that a learning health system is a bit different than more traditional models to change.
Thanks, Christine. Amy or Jennifer, did you want to add to that before we go to the next question, or hit the main points?
I mean, I'll add a little bit maybe, in just that, as hard as it is to understand learning health systems, I feel like it's just as difficult to distinguish between what's a learning health system approach, what's quality improvement, what's research, what's evaluation. There's such minute differences between each of them. And like Christine said, I agree they can all kind of use the same approaches. I think it just depends on the specific context. So I think it's hard to answer without like a specific example. And then it's easier to kind of say, well, this is a research approach because of the way you need to collect data or the population, right? So it's I think it can be hard to answer that question broadly. And I guess it's a bit about orientation would be the other piece I would add around what's different between them. And like learning health systems, yeah, I think aim to kind of bridge that gap between generating knowledge and applying it.
Thanks, Amy. Jennifer, I see you're off mute, so I'm thinking maybe.
Oh, I was just going to say the people at the front lines, they know what's not working. And a lot of them have good ideas for change. So I think just like I know somebody asked about where do you jump in when starting? And I think it's more to do with just having those conversations ongoing, because clinicians have to learn a ton of stuff and they have to be continuously learning a ton of stuff. So if it's not relevant to them right then, they're not going to even be concerned about it. So
yeah, thanks, Jennifer.
the
And I think
conversations.
Yeah, I was going to say it relates to your point about conversations and relationships when you were speaking earlier. And just for everyone else who isn't also monitoring the chat, where Jennifer is talking about jumping in, we had a question from Corey Smith. They said, I see this as a culture change, particularly within departments and institutions. Do you have any practical ideas or steps on how to start this? And the graphics are mostly circular, so where do we jump in? So that's that element of what's our starting point in all of this. And I think, Jennifer, you're kind of talking about building on those relationships, and conversations will help you identify starting points. And then Christine, Amy, I don't know if you want to add to that.
Just that Jennifer, I think Jennifer's comments spot on to how I interpret that too. Yes, it is circular, but if we think about where are our priority issues coming from, they need to be coming from patients, public members, kind of we have it as the community in the MSSU's version, and then also providers. So Jennifer's example of, point of care staff know the issues. And so that's along with patients and members of the public, that's where we should be starting. So if you look at the graphic kind of in the practice and policy piece, then that leads to what data should we be collecting? What data are we not collecting already that we should grab from the research evidence? And then that kind of circles back into the cycle. It's not iterative. It is intended to be a circle for that reason, but I think intuitively that's where I see that priority setting happening as a first step if you're trying to jump in somewhere.
Yep, definitely. And I can see in the chat that a few others have picked up on that point about community being very inclusive. So not just what clinicians or frontline workers might see as priorities, but Linda Wellen made a point about asking patients what's working or not. So having those kind of conversations with different perspectives are so important in that process. We had another question in the chat from Frank, who asked how we can ensure time for clinicians to participate in these types of projects or activities. And I think that's a perennial challenge. Jennifer, I think you spoke to that a little bit around the priority setting. So if it's picking up on things that are kind of pain points for clinicians.
And actually I can go back to some experiences that I had as an educator. There were some priority things that came up that we had to have discussions with staff about, and people were too busy to attend a session or they couldn't leave their units. So we decided we were going to do walk-arounds, talk one-on-one with nurses and help them with their work while we were talking. So you have to be as creative as you can be, because that's the reality. Like I worked with somebody one time who said, I think everybody should go out in the parking lot at the beginning of their shift and do calisthenics. I said, who's looking after the patients? And so like, you have to put a lot of emphasis on, you really got to put the patients at the center of things.
Yeah, that's a really good point. And Christine, I know you're working in a clinical environment too. I don't know if you have any thoughts on the time crunch clinicians face.
Yeah, it's a really good question. And actually, my mind goes back to, I think, Corey's comment above that is, this really is a culture change. And so I don't see it necessarily as, oh, you get X amount of hours to work on this learning health system project, right? If we truly are embracing this culture of continuously learning, continuously looking at different forms of data, whether that's patient experience, provider experience, health administrative data, and then using that to inform next steps. I see that more so as the way to go versus actually having, dedicated time. Now that's easier said than done. I recognize that. But I think it comes from leadership. We've worked with some units, for example, at the IWK, where we've been using these types of implementation science methods, knowledge translation tools with them. And it really is has changed the way that they approach practice changes. It can be as simple as just, if nurses are in the middle of charting and they're kind of all around the nursing station, quick conversations. It doesn't need to be a big, robust research study, but quick conversations to get their input. moving on to the next step. And so you're really seeing the difference in those types of units that have embraced this different way of informing change on their unit. So I think it's possible without having, you know, specific FTEs for clinicians' time.
Thanks, Christine. That's a really great point too about how it can be small. And I think maybe there's a little bit of, you can find people who have an interest in that kind of culture change as well. And just by virtue of knowing that some of your nursing colleagues have been consulted even in a small way, that might help with kind of the uptake. So you can find a few people who have a time and an inclination, and maybe that involvement helps with like the broader kind of stakeholder group too. Okay, so we've got a couple minutes left. I don't see any other questions in the chat. Oh, wait, something's just popped up. We have a comment from David Petrie. He says, excellent stuff, thanks. I noticed from the Meniere graphic that the cycle of learning sits on top of foundational pillars of governance, leadership, culture, etc. It's a bit of the chicken and egg paradox, but if we don't have those pillars, or if that terroir in an ecosystem, oh, sorry, I've got in a more ecosystem-y metaphor, is hard to really get embedded researchers where they need to be, i.e. at the strategy setting, policy making, project planning tables. Yeah, that's a really interesting point. So kind of there's a lot of pieces to this that kind of create the environment or the setting for it. How do we get that in the right place? And then you talked a little bit about embedding researchers, Christine, as coming out of those previous studies. How do we make sure that they're getting right to the sort of start of things?
Yeah, I think that the chicken and egg, you know, metaphor is exactly correct. It's, what am I trying to say? It's hard to say, okay, now you have an embedded researcher, so all is going to be fixed. If the research that's being done isn't necessarily valued in the decision-making process. So chicken or the egg, or I'm picturing kind of just a really messy ball of yarn where you're pulling one side and it's not really helping the other. And so I think that it's another part of the culture change of if we have researchers that are part of a health system and part of a team, not just seen as something that's external, that'll help also with those pillars of a learning health system, and specifically the values that are mentioned in the Meniere framework.
Thanks, Christine. Yeah, I think the embeddedness one is interesting too, because we tend to talk about it with researchers, but maybe not so much with patients. I think the perspective is because we're talking about health system settings, they're there by default, but I'm not sure that they are at kind of the priority setting stage for some of these things. So I think maybe that's a kind of component to keep in mind too. Jennifer, I see you nodding.
Yeah, it's hard to try to involve patients who are on the units because they've got other priorities at the time. So you really do have to be thoughtful about, is there somebody that could speak for patients? And I think there's so many people out there that are interested, and a lot of the health regions now have their patient advisors and a lot of people involved. So I think we're going in the right direction. And I think as long as you I think you need to get the appropriate patients in there as well. There's no point in putting me in like labor and delivery because I've never worked there. I've had babies, but it's not the same thing, it's like, anyway, so.
Yeah, no, I think that's a really good point too, and that we also have some infrastructure because we have this tradition of patient-oriented research and a tradition of involving patients in quality improvement projects. So maybe LHS can build on some of those experiences. And I think your point also relates to our kind of final comment from the chat from Anam. Apologies if I'm pronouncing that incorrectly. And they've suggested find champions who are interested in making changes in the healthcare system. So that's a point that we touched upon earlier. So we're coming to the end of our time together. I just want to thank our speakers again for sharing their thoughts with us, and to everyone who's joined the discussion, participated in the Menti poll. It's been a really helpful chat. I will just quickly don't run away yet. I'm going to drop an evaluation survey link in the chat. So if you feel like sharing your feedback while it's fresh in your mind, we really appreciate that. And I'll also send the link out in a follow-up email, which will include the link to the video and the interactive graphic and so on. So that'll be coming as soon as the video is online. So thanks again, everyone, and have a good end of your year. Happy New Year, and take care.
Thanks, everyone.
See ya.